Andy, that was great. Thanks so much. And we're just going to bring the questions up here on the slide for you, Andy. I'm also going to invite Josh to join as well. But we're going to start off questions for yourself, Andy, related to your talk. You can see the questions there. Do you see any connection between the exacerbation of ADHD symptoms, if not their onset, between this disorder and the multitasking world we're in, social media, where distraction and multimedia is common?
Absolutely. It's a very simple yes and no question. Absolutely. As the cognitive demand has increased and various social supports, for instance, now we move around a lot more. There's a breakdown of our families. There's a breakdown of religion, if you will. I'm not necessarily promoting religion, but in the old days, people would go to church. They had structure, more structured routine. We had a lot less things bombarding us with information. This has increased the cognitive demand tremendously. There's a lot of data that the diagnosis of ADHD is increasing, and whether that represents a true increase in the prevalence of ADHD or an increase in the recognition, or that we're just uncovering people who were able to compensate and function in previous eras, but now with the increased demand, it's coming out. So it's absolutely the case.
Absolutely. Good. How do you know which to treat first, mood, anxiety, or ADHD?
Such an important clinical conundrum. Well, our thinking has actually evolved on this. It used to be you assiduously treat the mood disorder first, or the anxiety disorder first, and then the ADHD. Now we have a more nuanced approach, and I think of primary versus secondary. So there's a lot of anxiety and dysphoria that is secondary to the consequences of the ADHD. Adults will tell me, I can't sleep, I'm constantly worrying, my mind is always going, I'm worrying, what did I forget? What do I have to do tomorrow? Well, that's a secondary anxiety. But when you see someone who has early onset anxiety concurrent, also I look at the content of the thoughts. So if the content of the anxiety thoughts is obsessions around germs, for instance, or social situations, well, then that might be something that I'm going to treat concurrently with the ADHD. But if it's the secondary, if it was the former, I'm going to treat the ADHD first and see what's left. Now, certainly, if it's a mood disorder and I have suicidal ideation, or I think it's bipolar disorder, I'm going after that aggressively first. There is, to that point, there's a lot of emerging literature now that it's very safe to use stimulants in patients with bipolar disorder as long as they are adequately mood stabilized, either with a mood stabilizer or an atypical antipsychotic, something that I do routinely. And I certainly in inappropriate patients, of course, if they're substance abusing actively, then you have to be careful. So that's sort of some of the ways that we think through that.
Great stuff. I'm also glad you spoke to that topic of bipolar. I agree with you, Andy. How often do you hear the patients on stimulants for a significant period of time that no longer benefit from the medication prescribed, the stimulant? And
Yes.
What then do you do in addition to reevaluating the diagnosis?
Yeah, well, I like the latter comment. Of course, you always reevaluate, but there is a real phenomenon I want to alert you to, and that is a tachyphylaxis phenomenon with stimulants. After 1 to 2 months, well, let's say you get somebody dose optimized on a stimulant. After 1 to 2 months, they will tell you that it's not working as well. It seems like it's wearing off, and that's a real phenomenon. They're not just trying to game you to get more stimulants. We don't know if it's a pharmacokinetic phenomenon or a pharmacodynamic phenomenon. Either the body's more efficient at clearing the drug, or the receptors or the circuitry adapt in the brain. What we know is if you do one dose adjustment up, typically that fixes the problem and you're good to go. Now, I do believe that it is possible that some people do become a little more recalcitrant over time, perhaps. And what you would consider in those cases would either be a switch to the opposite type of stimulant, so from methylphenidate to amphetamine, for instance, or vice versa, or an augmentation strategy. So those are some of the ways I think through that situation.
Great stuff. Here's one: impulsivity, so common ADHD, and you say impulsivity is a factor in suicide. Do you see a link between ADHD, impulsivity, and suicidality?
This is a really timely question. There was an article just published a month ago on this exact topic that I recently read, and it turns out that adults with ADHD or who are having financial stress are 3 times more likely to commit suicide. Now, how relevant is that to the COVID-19 epidemic when a lot of people are facing financial stress? Also, the suicide rate amongst adults with ADHD is significantly higher than the non-ADHD population, and the suicide rate increases dramatically with each additional comorbidity added to ADHD. So the answer is a resounding yes to this question as well.
Yeah, great question. We work with a colleague, Vincent Chen, in Taiwan, and he had shown in a database we work with him on that methylphenidate for 6 months or longer lowers suicide in Taiwan due to this anti-impulsivity effect. How often do you hear that patients on stimulants for a significant period of time no longer benefit? How often does that happen, this tachyphylaxis?
Well, the tachyphylaxis I mentioned within the first 1 to 2 months is almost universal. But as far as the longer term situation, I don't know the exact answer to that. I'm sure it happens in some significant percentage, perhaps 10 to 20%. The data we always see is that 30% of patients with ADHD are non-responsive to stimulants. I don't know if that's true. I loved Josh's talk about adherence and about really examining true versus pseudo treatment resistance. I think that really applies here. The data shows that a super high majority of people also stop their ADHD prescriptions after a couple of months. So, you know, you have to reevaluate compliance adherence also.
Yeah, absolutely. So Josh, that's great. Stay with us, Andy. We got in our last 9 to 10 minutes, we're going to go through what I call the wiki question and answer period. So short snappers. And look, folks, we got over 100 questions coming in. We're not going to be able to address them all. This is a lot of just great questions. But as I said, we're going to archive the program on the website, www.bcdfoundation.ca, and we're going to have some of these questions addressed there. Let's get started. Some wiki answers with regard to wiki Hawaiian for quick. So nice and quick. With regard to ketamine use, how long should we use IV ketamine or IN ketamine for treating TRD in patients? Josh, that's one question. And then maybe the question about abuse potential. Those are two questions.
Yeah, so for the, I'll answer the abuse potential question first. So the data does seem to be clearer and clearer on this, that the abuse potential for ketamine, IV ketamine, and intranasal S-ketamine is very low. I think we still have to be very careful, but the capture rate, meaning the percentage of people that would become addicted to ketamine after using it once, would be extremely low in the single digits. And there really is just case report level data. And there's the added security of there's no take-home doses where patients can start to overuse or divert. IV ketamine they're getting in the clinic, INS ketamine they're getting in the clinic. So there's much lower potential in that regard. So I think, unfortunately, that's one of the cautions of ketamine that's probably blown out of proportion that we need to be mindful of, but isn't a major barrier in my mind. And then in terms of how long to continue treatment, this is still a bit of a question mark. And for the patients that I treat at the Rapid Treatment Center, these are predominantly patients that are severely depressed, suicidal, patients that are going to the emergency room multiple times a month. And so we do end up continuing, and it all comes back to informed consent, saying that we don't have the long-term data for this, but it seems to be working, and there might be some long-term side effects that we don't know about yet, but we continue it and we try to decrease the frequency over time. Once we get to a point where they're getting infusions less than every 3 months, if they've had significant changes in their life, such as improved psychotherapy skills, improved psychosocial supports, then we look at potentially discontinuing them. But I don't typically look at discontinuing unless there's been a really good period of stability and the frequency of boosters is less than 3 months.
Great stuff. Josh, just a quickie. Any serious side effects when you stop ketamine?
Main thing is just return of symptoms, where there isn't a withdrawal phenomenon, but those nice antidepressant, anti-suicidal effects, they likely would wear off. And so return of symptoms is the big concern.
Josh, your own personal experience, what's the longest time you've had a patient on ketamine in depression?
2 years, basically, since there was a few people that started since the clinic opened that are continuing on with boosters right now.
Yep, similar to myself. I'll maybe jump in about 2.5 years for me. So similar to Josh. Next, and then we'll keep going to the next question. We did long-term use already. Maybe another question. Josh, improvement following ketamine does not seem to last. That's true. I guess a big question. What's the best way to try and prolong the benefit of ketamine, given the state of the art today?
Yeah, great question. So the first part of that is having an acute course. So even though the initial clinical trials were with single doses, we now know that a series of 4 to 6 repeat doses twice weekly is much more effective than a single dose. So you'll not only increase the number of responders and remitters, but you will increase the duration of effect. In addition to that, in terms of other things that would prolong the effects, very preliminary data on potentially combining cognitive behavioral therapy to help prolong the effects, continuing on gold standard pharmacotherapy in terms of continuing on their antidepressants, since this is an add-on treatment, would be important as well. And there is some early studies on combining certain medications, like, for example, rapamycin, that targets the mTOR pathway, that may amplify and increase the duration of effect. So key question that we're working on, but those are the main things right now.
Great question. Quickie here, Josh. Does an anesthetist need to be present for IV ketamine, S-ketamine, or both?
Yes for IV ketamine, no for intranasal S-ketamine. Intranasal S-ketamine would be a healthcare provider. That could be a medical doctor or a nurse, but does not need to be an anesthesiologist. For IV ketamine, absolutely need an anesthesiologist there on site, and that's a CPSO requirement, full stop.
And just so everyone's clear, a nurse can give S-ketamine. You don't need an MD on premise. We'll have the next question coming up here. Okay, another one, Josh, lots of ketamine is coming in. With regard to ketamine, how long should we use? I think we've talked about that one. Maybe we'll go on to the next one if we could. That one seems to, we've covered that one already. Okay, Josh, how important is it to understand the target symptoms at the time of the first episode? In other words, when selecting an SSRI or SNRI for a newly diagnosed, we'll even say medication-naive patient, does the symptoms really matter? Is there any type of portraiture of the patient's depression that increases the likelihood of success on one agent or class versus another?
Yeah, so the research on this would suggest that no, that this sort of tailoring does not improve outcomes, but my clinical experience and I think common sense would suggest that some tailoring is beneficial, where if you do have your lethargic, amotivated, cognitively dysfunctioned patient with depression, an SNRI just makes sense. But the research doesn't necessarily support that practice at this point, even though it is what I do.
Yeah, I agree. I think about half of the patients get emotionally blunted in SSRIs. That's a big issue in terms of the various agents. Now, bupropion, very simple. It's a fixed dosing strategy with this particular medication, and it's in the extended release. And it's a single dose week for the first week, twice, 3 the third week, and 4 in the fourth week. I remember for many years we used to combine the naltrexone with, in fact, bupropion in our own sort of little way of 50 milligrams or 100 milligrams of naltrexone with 300 milligrams of bupropion. But the company has this fixed ratio of naltrexone to bupropion in this particular strategy. So, in fact, it's very simple to dose. 1, 2, 3, 4. Next one. We got time for a couple more questions here. When a patient has bariatric surgery, does this lead to changes in brain circuitry? Absolutely. It's a great proof of the concept. Studies have been shown pre versus post bariatric surgery that there are changes in brain. There's changes in brain circuitry. There's also changes in the periphery. No surprise, there's reduced inflammatory markers. There's improvement in insulin signaling. No one's surprised by that. What's especially interesting is that on pencil and paper cognition testing, there's also an improvement post-bariatric surgery. What many might know, however, is that about 5% of people post-bariatric surgery have new onset depression or relapse of depression or new onset suicidality or relapse suicidality and or drug and alcohol misuse. So that is obviously concerning, and that is conceptually as interesting with respect to the concept here. So some people, in fact, about 3 to 5% approximately post-bariatric surgery have this disturbance in cognitive control and or reward behavior manifest itself. So that speaks again to this concept. Next slide. Okay, we'll finish off with this one. The MDQ does not seem to be a very good screening tool for bipolar 2. What do you recommend on top of this? I'll leave this open for both Josh and Andy. This is our final question.
Andy, please go ahead.
Oh, okay, sure. Well, this is an important question. The MDQ is agnostic for bipolar 1 and bipolar 2. It can pick up people with bipolar 2. What I find is I always review the MDQ with the patient and give probes and prompts and examples. There is a new test, a new screener in development called the RMS. What I really like about this, it's the Rapid Mood Screener. It'll be available very soon. Roger was involved in the development of it. It actually includes questions not only about mania, but also about depression and the quality of depression. So I think that might be an improved tool. But this is just a tool to augment what you do as a clinician taking a careful clinical evaluation. Beyond the scope of this talk, but I have a whole nother talk on clues, 5 clues that your patient with depression is actually bipolar, includes things like genetics and a response to antidepressant medications. Early onset of depression is a very big clue before the age of 25. So a couple of teasers.
Yeah, I would agree with that, Andy, entirely, and really appreciate that. And indeed, bipolar 2 continues to be, unfortunately, a neglected orphan in the bipolar area. But I think that, to Andy's point, thinking about those bipolar validators, age at onset, the number of episodes, and family history in response to treatment. So, as is always the case, these programs go by very, very quickly, and we purposely booked a finite period of time, a fairly tight period of time for this, because we know that it's a Saturday, and also the Zoom fatigue phenomenon and so on. But I wanted to, in fact, first of all, thank Andy. Thanks so much for that, and Josh, thanks as well for 2 excellent, clinically relevant, and really top line and top quality presentations. And I also want to thank as well the sponsors again, AbbVie, Takeda, Bausch Health, and Janssen for making this possible. We appreciate it. You're all, in fact, going to be hearing about next year in 2021. We all cross our fingers for a in-person program, and we're looking forward to that. Let's keep our fingers crossed for that, but we'll certainly go virtual if we have to. You'll receive, in fact, an email regarding an evaluation of the program. Look for that. We value your feedback, especially for next steps and other topics. And also, again, a reminder that the program will be archived on our website, www.BCD Foundation. We're all busy. Time is precious. We wanted to have an opportunity for this knowledge exchange, especially during this time, this incredible public health and mental health and economic crisis that's going on. We hope this is interesting and relevant and translates into your practice, and let's hope it can improve outcomes for people that we have the privilege to provide care for. So thank you to all of you, and I bid you all a very good afternoon and a good day.